again to the Professor A.D. Sir's Virtual Clinic 2.0. So with Professor Devdas Sir's vision of teaching the young orthopods as a motto, so we're inviting the senior speakers across the country to teach the young orthopods. So with the continuation of that, I invite and welcome today's speaker, Professor R.H. Govardhan Sir. Welcome to the forum, sir. Happy to have you. Thanks for joining us. To the brief, the introduction, Sir is a founder and director of the HOD of the Madras Medical College. He held prestigious positions in IOA and TNOA. Sir is a surgeon of the par excellence. He has operated many complex cases, and he's an excellent teacher. And many postgraduates have been passed and trained under him. And we're happy to have you, sir. And sir is the founder director of the Vasanthi Orthopedic Medical Center in Chennai. Sir is going to speak on non-union of a fracture, and he will share his experience on that. Over to you, sir, for the presentation.
Thank you, Deepak, for the kind introduction. I'll share the screen and first of all, I would like to thank my mentor, Professor Devadas, for providing an opportunity to be part of this virtual clinic, Professor A.D.'s Virtual Clinic 2 for graduates, which is being conducted by the DMH IORAS Madurai. It is a pleasure to be here to give a small talk on it's not progressing.
Just click on screen once.
Speak on once?
No, click on the screen once. Using
Okay.
your mouse. Click on the screens.
Fine. So we are going to talk on okay. Sorry. I'm going to talk on non-union of fractures and its case discussion. Non-union is one of the short cases which any postgraduate will be facing in the examination. Of course, fracture neck of femur non-union is a long case, and most important is clinical examination of these non-unions. The paramount important of eliciting few clinical scenarios are very, very important. You have to find out whether there is abnormal mobility at the fracture site, whether the skin condition is all right or not, especially non-union of the tibia can have adherence of the scars because of the old open injuries, which may have deleterious effect, or the modalities of management may be different. So you have to be very particular about the skin condition, the elicitation of the abnormal mobility at the local site. If it is going to be juxta-articular non-union, one has to elicit the abnormal mobility holding the distal fragment very carefully. The catch point, most of the distal or metaphyseal non-union will be the elicitation of the range of movement of the particular joint. The range of movement has to be shown to the examiner. Usually, when you are eliciting the range of movement, the abnormal mobility will give some sort of abnormal range of movement in the joint. So you have to really catch the distal fragment, show the range of movement. And if you are dealing with non-union lateral condyle, then you have to catch the non-union of the lateral condyle, show them that there is an abnormal mobility. You have to see the shortening in a particular case and how much is the shortening compared with the opposite side. Neurovascular deficit has to be seen in a clinical scenario. In non-union neck of femur, one has to show the telescopy, and the demonstration is very, very important apart from all other things. So I welcome from our hospital, Vasanthi Orthopedic Hospital in Chennai, to give a glimpse of non-union of the fractures. Now, most of these fractures do heal, and if you see the fracture healing pattern in the humans as well as the animals, in animals it is very difficult to get a non-union unless otherwise you create a big gap between the two bone fragments. Most of the animal bones do heal, and if you see any dog or the cat, if they have got fracture, they may just shrek off their limb for a while, and they will walk with the three of the legs. And after some time, once gradually the callus forms, they will put the leg. Like that, most of our fractures do heal. There are certain fractures like fracture neck of femur, neck of the talus, scaphoid fracture, fail to unite because of the peculiar blood supply. Because neck of femur derives from one particular branch from the medial circumflex artery. Neck of the talus has got a particular branch from the body to the from the neck and the head to the body, and scaphoid similarly has got the peculiar blood supply, wherein one fragment becomes totally avascular. So union between the vascular and avascular becomes difficult. It also depends on the soft tissue damage one's get. If the soft tissue damage is too much of the periosteal stripping is there, you get devitalization of the uh, extraosseous element of the bone, which may cause a delayed union and non-union. In open fractures, soft tissue stripping is more, and the chance of infection is always there, which may delay your healing. Usually, the aseptic non-unions follow after the operative intervention. This is an example of a person who came to me after 12 years of its fixation of the humerus. You can see that the fellow had a third fragment in the shaft of the humerus. There were 4 screws in the distal fragment, 3 screws above. After 12 years later, he had this non-union where the plate is just held with 1 screw. Rest of the screws have fallen down in a pocket. This is a typical non-union aseptic without any evidence of infection, which is almost like a pseudoarthrosis type. Example where the radius has been fixed with a distraction, which has caused non-union. Anla has been just fixed with 5 screws with a plate, which is an inadequate fixation, which has gone on to a non-union at the side. This is a very interesting case where the patient, the surgeon was confronting a stage where there was a gap in the radius. So the gap, he tried to fix it with the help of opposition of these fragments, causing the inferior radio-ulnar joint subluxation. And the gap which was there in the radius was grafted, but it was not adequate enough to go on to a union. So it presented as a non-union. So a distraction, inadequate fixation, a bone gap, they all can lead into a non-union. This is a mid-shaft fracture with a lot of comminution, which has been fixed with a plate. You can see that the plate proximal screws, there are only 2 screws above the level of the topmost third fragment, which they have got it. Most of the time, if you try to get an anatomical reduction without bothering the soft tissue component of these fragments, they all get devitalized, which leads on to a non-union, and which is evidenced by a blending of the plate. So you can see these 2 arrows show that that is the extent of the fracture, and you have just got 2 screws above and 4 screws down, which is an inadequate fixation for a shaft of the femur. This is also another example of a subtrochanteric fracture in a 17-year-old boy with a lot of comminution, which has been just fixed with 3 screws above. A broad DCP has been used. So these are examples where inappropriate fixation and inadequate fixation has led on to a non-union. Let us define what is non-union. Definition of non-union classically says that it is evidenced by painless abnormal mobility. I am always wondering why a person has to have painless abnormal mobility. Usually, if you see various types of non-union, you will find that the patient will complain definitely of a pain. I am glad to see that the literature has changed, and no more the definition has given as painless abnormal mobility, but they all have now told AO group, various other textbooks, they all have given definition. It is abnormal mobility, not painless abnormal mobility. So non-union is the status of fracture wherein the healing process of the fracture has ceased, clinically judged by abnormal mobility at the fracture site, radiologically shown with a gap at the fracture site with the absence of a bridging callus in the beyond the expected time of healing for a particular type of a fracture in the corresponding age group. For example, a fractured tibia in a child will heal within 6 to 8 weeks period, whereas it takes about 3 to 4.5 months. So this is an arbitrary time which varies in the various age groups. So when you are defining a non-union, you have to tell the age group as well as the type of the bone which is involved. There is also a term called delayed union. What is the difference between delayed union and a non-union? Now, fracture healing is not taking place within the expected time, of course, for a particular type of a fracture in the particular age group. In this status, there is a possibility of union if treatment is continued without any intervention. So basically, in a non-union, you don't expect itself to unite the fracture, whereas in a delayed union, there is a possibility that if you try to continue the immobilization, it might heal. So this tabular column shows the difference between non-union and a delayed union. Clinically, duration more than 8 months with mobility is non-union, whereas delayed union less than 6. These are all for adults, long bone non-unions we are talking about. Less than 6 to 8 months. Mobility is not frank mobility, but there is little bit of mobility. Pain is slight in non-union, which is in delayed union it is more. Radiographs sclerosis ends with closed medullary cavity is seen in non-union, whereas there is no, the medullary cavity is still open. The ends are not sclerosed. Is there any need for change of treatment? Usually required for non-union, may unite without change in a delayed union. Non-union gap may be present in both. Non-union is diagnosed in patients who have got implants inside. If they have got pain at the particular time, after a period of particular period, for example, a tibia has been nailed in an adult and he complains of pain after 6 months later at the fracture site, you must suspect that the patient has got definite non-union or a delayed union. The non-unions are classified by Weber and Cech in two broad categories. One is a hypertrophic, the other is an atrophic type. Hypertrophic is where there is hypervascularity. There is definite attempt at formation of the bone at the local site, but the bone does not heal because of the lack of mechanical stability. It could be an elephant foot type or a horseshoe type, or these are the two varieties. There is one more variety called oligotrophic, which is not a frankly hypertrophic, but there is lack of callus, but otherwise the vascularity of the two ends are good. Atrophic non-unions, there are varieties which are shown here. One is a torsion wedge. You've got a third fragment in which one it is in contact with the proximal fragment, whereas it is not having any contact with the distal fragment, which leads on to a delayed and non-union. Comminuted third fragment, which is shown as a second variety, is one of the cause for non-union because of the avascularity of that fragment. If we have got a big gap in the fracture side, definitely it is a atrophic type of a non-union. And the fourth variety is the one where there is formation of a pseudo joint with synovium inside with fibrous tissue formation, which is a pseudoarthrosis type. These are the broad classification which Weber and Cech have given to us in 1976. And based on this, the treatment modalities are being formed. Now, Ilizarov classified into broad classification. One is stiff non-union. The second one is a mobile non-union. A stiff non-union is one where it resists deformation. There will be abnormal mobility, but it will resist the abnormal translation of movement. If you give more force, there will be definitely pain. Radiologically, the ends may be sclerosed like this, but they have got good opportunity for bone healing once this stability is given at the local site. What is the management of this stiff non-union? According to Elizarov, if it is without any deformity, you stabilize these fractures with adequate fixation, compress it with 0.25 millimeter 4 times in a day, and intermittent distraction. It will cause union at the fracture site. Now, if there is a deformity along with the stiff non-union, you correct the deformity and compress, you will find the healing. Now, not all people are Eliezer of Savoy, and there are methodologies in which you can correct the same stiff non-union, which is very similar to that of the hypertrophic non-union, what we were talking, or what has been shown in the AO manual. Now, these are the two situations which I have taken from the AO manual, where the femur has been nailed with an uh, without any interlocking. It's like a kunchal nail, where the bone is in good alignment, but it has not healed and it has caused a hypertrophic non-union, wherein you can do ream the canal again, put an interlocking nail because the alignment is good. It is what it requires is a more stability at the level of the fracture site. Rotational stability is provided, then it will heal, which is afforded with the interlocking nail. Second example of a fractured tibia where there is a hypertrophic non-union. You don't have to do anything with the hypertrophic non-union. You have to compress with the plate. You can see that the compression device, Muller's compression device, has been used to correct a varus deformity at the level of the non-union, and the plate has been contoured so that the callus which is formed at the local site is not at all disturbed, and you compress with the help of a Muller's device, give adequate stability at the local site and compress it. That's all it requires for a healing. There is no need to disturb this hypertrophic callus. There is no need to go into the fracture site. There is no need for a bone graft. They all will heal on its own. I will give you an example. Sorry. Deepak, I think there is a mistake in opening up the my PowerPoint. Okay.
No issue, sir. No issue, sir. You can open the new one, sir.
No. I think I'm all right. I'm all right. Fine. So now, this is an example of a child who came to me with a non-union following a road traffic accident. That was a very small metaphyseal fragment, and we put a frame because that is a very, very small fragment which cannot be held in by any other methodology. We corrected the deformity. You can see the callus which has formed at the local site. Example of a doctor who is a practicing doctor in Puducherry. This gentleman had a fracture distal end of the tibia, which was earlier fixed, and he had an infection. They removed the implant, and since he was an uncontrolled diabetic, 2 or 3 attempts at doing internal fixation has failed to unite this. When he came up, we saw that there is a deformity, and the X-ray showed that the ends are still having sclerosis on both sides. So a simple correction of the deformity with stabilization of the foot and correction of the deformity caused a good bone formation and healing of the fracture. So these are the type of hypertrophic non-union with the deformity. Once you correct the deformity with an adequate stabilization with the help of the ring. I have not bothered even to remove those one screw which has been left there, and the bone has nicely healed, and tibia as well as the fibula has healed. He has got a good alignment, and he is walking. If you have got a mobile non-union with abnormal mobility, it could be an atrophic type or a synovial pseudoarthrotic type. Management of a mobile non-union atrophic type is in an Illusorov methodology. You have to compress the mobile non-union, increase the stability of the bone at the non-union site. If necessary, add bone graft in cases of synovial pseudoarthrosis type. Rest of the mobile non-union, which is atrophic type, they give only compression and distraction, or what is called as accordion maneuver, to get the union. In a conventional type, where people are not very much conversant with the Illusorov type, what is to be done is you have to open up the non-union site with an osteoperiosteal flap. The importance should be given to the periosteum as well as the soft tissues which are covering at the local site. Indiscriminate stripping of the periosteum may not help in healing the fracture. So it is better to take the periosteum along with chiseling of the bone, which I will show you later, and you excise the fibrous tissues which are there at the level of the non-union. Bone ends are made to raw, and then open up the medullary canal, stabilize the fracture after reducing it with good end-to-end opposition. If possible, compress the fracture site and add cancellous bone graft. Best bone graft is the autograft which you harvest from the person. We all are aware that the bone graft harvesting has got its own problem, but even then, that is the best one because it is osteoconductive, osteoinductive, and it works like a scaffold on which the bone will form. This is an example which I took it from the EVO manual, where the periosteum along with the bone is chiseled off so that you get an osteoperiosteal slip. Now, this is example where they have taken off the osteoperiosteal slip on both sides, which makes the ends raw, and then you add up onto that the bone graft so that you will get a union. Now we'll go to the example where there is an aseptic non-union with a gap. This example which I showed earlier, this is the radius where there was a gap which was tried to neutralize with the help of shortening of the radius, resulting in inferior radio-ulnar joint dislocation. This lady had restricted supination pronation with non-union, gap non-union. Now, we analyzed this and we thought that the best one is to do a Savo Kapanji procedure because you can harvest the bone graft from the ulna and the shortened distal end can be fused with the distal radius, thereby creating a good wrist joint the local side. Ulnar variance is taken care. Your bone harvesting is not done from the iliac crest but from the local ulnar side, which was kept as a gap between the two ends of the radius bone after making the bone ends raw. This is a serial X-ray which shows that the graft is very nicely taken over and the non-union healed. This is the function of the lady with supination pronation, and that is a supination pronation. That is the function of the wrist dorsiflexion as well as the palmar flexion. Earlier, I have shown that this is an inadequate fixation which is done for a 17-year-old boy who had a subtrochanteric comminuted fracture. The treating surgeon has fixed this and he has also harvested a lot of bone graft from the iliac crest, which failed to heal because of the inadequate fixation. Probably this would have been better off with the help of a nail. But when he came, he was a very plumpy fellow, and we thought that after removing all this plate, it will be better to stick on to a plate. So a reversal of the right side distal femur plate was applied, which we thought that adequately we have fixed with 7 or 8 screws proximally and distally 6 or 7 screws. And that fellow was very much apprehensive of getting a graft from the other side of the iliac crest. So we used bone graft substitutes at the local site. And we were very happy that the bone graft substitutes also healing in the August 2018. But in January 2009, he came with pain. We found to our horror that there is a fracture of the plate, which means that there is still non-union at the local site in spite of all our attempts. So we removed the plate. We went back to fixing with the help of an intermedullary fixation, and that in 5 months' time, the entire fracture healed, and he has started going to the college. Segmental fractures are notorious for non-union because the middle fragment has got vascularity on one side, the other end may not have vascularity, and the middle fragment itself is become avascular. Normally, it heals at one end, whereas the other end may end up in a non-union. The reason is like this, where there is comminution is there, you can find that comminuted portion may heal to one end, but in between the comminution, it may end up as a non-union as shown. Though there is attempt at union or bone formation by the periosteum, still you can see that the non-union comes. Example of a segmental fracture of the tibia in a 60 years old gentleman who had the plating done. Uh, you can see that the proximal segment of the segmental fracture has healed, whereas distally where there is comminution, it has failed to heal and it has also caused breakage of the plate. So we just removed all the implant, put an interlocking nail with quite adequate amount of bone graft to the local side to get a union in 4 months' time with a good function of the limb. If you've got a mobile non-union like this, where it was a post-osteomyelitic or post-infective sequelae, where there is a real pseudoarthrotic type in a middle-aged woman who came with a rural area, and she had to we have to clear all the areas. Since it was a old compound injury, we didn't want to put any of the implant there. We stabilized with the help of the frame, Elizera frame, and we added adequate amount of bone graft local site. To get a compression at that local site, we also shortened the fibula, and that is 8 months post-op. You can see that the pseudoarthrosis type has completely healed with a good amount of bone formation at the fibula as well as the tibia. If you have got a synovial pseudoarthrotic type, you have to excise the pseudoarthrotic joint, fibrous tissue, excise the necrotic ends at the non-union site, open up the medullary canal, get a stable fixation, add cancellous graft, and that will heal the fracture. This is an example which I showed you, which is a 12 years old non-union with a lot of bone resorption of the local side with a ballooning of the cortices. This gentleman had only a small segment of the bone in the distal fragment. So after removal of all the implant, we cleared everything. We added a lot of bone graft, used an Elizera because the fragment was so small. So with 3 wires and pins, we were able to get a good fixation, and which went on to heal nicely, and he has the function after removal of the frame. Now, Paley has classified this non-union in two distinct varieties, A type and a B type. A type is where non-union with less than 1 centimeter of shortening. In A type, the first one is a mobile non-union without any angular deformity. A type 2 is hypertrophic non-union without any deformity, and type 2 is with deformity. We have already seen what is the management of these varieties. Whereas non-union, where you have more than 1 centimeter of shortening, of 3 types. The first type is where the limb length is maintained, but there is a gap in the middle portion of the tibia or middle portion of the bone, whichever bone which we are dealing with. B type, second variety, is there is shortening, ends of the bone are approximated, there is non-union at the local site. In this variety, since the shortening has been there, but bone ends are at each other ends. Whereas in type 3, there is shortening, there is bone loss, and that is a complex situation. This is an example of a boy who had a hypertrophic type of a non-union. You can see that the um, apex of the deformity, you have to fix adequately proximal and distal ring. You have to use 2 rings above, 2 rings below, put a hinge at the level of the apex of the deformity with a distraction unit on the opposite side, gradually distract the non-union side. You can see that the non-union has opened up very nicely and the bone is formed in between the two bones because it is a hypertrophic non-union where the ends of scleros, not all sclerosed ends of the non-union are avascular and it has to be thrown. These are the varieties where distraction provides you to callus formation. The end of the story where the deformity is corrected, you have got a very nice bone formation, and that is his limb after the healing of the fracture. In fact, he had a similar type of a problem on the opposite side for which he had the ring fixation. Now we will go to the B type of a Paley's classification and we'll see some of the example. Now, here is a gentleman who had a limb length is well maintained because the fibula is maintained in the length, but there is a gap in the local side. So this is a type 1 variety where we have fixation. After the fixation, we have done a corticotomy above and bone has been transported. You can find that the callus forms above, and once the ends comes here, you've got 2 options. You've got a broad ends of the bone. You've got a very good contact between the two. You can compress them and get a union. If there is a gap between the two and the opposing ends are not flat in surface, you can do your bone grafting at the local site, which this gentleman had and which resulted in a healing of the entire bone in 9 months post-op period. That is his function. If you have got a very big gap, very big gap, and you have got only one segment of the bone is longer, the distal fragment is very small, as shown in this figure, then you have to do corticotomy in 2 levels. I will show you an example. This is a real estate gentleman, hails from Chengalpat. He had a road traffic accident where he lost the almost 12 or 14 centimeters of the tibia. They have debrided, they have done a vascular repair because he had the vascular injury to the limb, and externally fixed the bone, and the gap was maintained with the help of a small Steinman pin with a bone cement covered on both sides. Once everything settled down, they send the case to me to deal with the bone gap. So the spacer rod was removed and we had the construct like this. Generally, I prefer to avoid wires in the calcaneum because they are painful and they will not allow to weight bear. So instead, I give orthosis so that they will stabilize the ankle joint. They will also stabilize, they will not allow the movements to happen at the fracture site. So 2-level corticotomy has been done And gradually you can see that the bone has formed, bridging the entire gap. And you can see at the end we had the we have to do a bone grafting at the end side, because these are all too small fragment. This is one big regenerate, this is another regenerate, and that is a small fragment which has brought down. So the amount of bone which is there will not allow you to compress and cause any problem. So we did the bone grafting at the local site, causing a good union. Metaphyseal non-union are different ball game, because there is a cancellous bone there, and you may find that healing that will be a very difficult. Now, I have got a very good example of a fellow who had a compound fracture of the proximal end of the tibia, where the patient had recurvatum deformity at the level of the non-union side. He also had a subluxation of the tibia posteriorly. That is his clinical picture. So initially, we tried to correct the angular deformity, which is the recurvatum deformity at the level of the fracture site, and we succeeded in that. But still, the tibia was posteriorly subluxed, which was corrected with the help of another ring above, so that we could get the subluxed tibia forwards. Now we can see that the subluxed tibia has come back to the original position. We did a bone grafting at the non-union side to get a good healing, and that is the end result. So metaphyseal non-unions are very difficult to treat, but if you are not using any Ilizarov, the availability of locking plates, anatomical locking plates, have really revolutionized, and it has given a lot of opportunities for treating such complex metaphyseal non-unions. Non-union in an osteoporotic bone is another challenge. This is a 68 years old lady, housewife, who is not a very great ambulator, was operated with DCS 5 months post-op. This is the picture with which she presented to my mentor. And what he did, he removed the implants and used DHS, a lot of bone graft. Inexplicably, in 6 months' time, she started drifting out, and you can see that the fracture is also not healing. Ultimately, the hip got dislocated. So at that stage, the patient came to me. We analyzed this non-union with the dislocation, and I thought that I have done a fantastic job, and can remove the implant and put a long stem and a bipolar. I have forgotten that there was a small chip of posterior lip of the acetabulum has gone while by the implant. So she dislocated again. So we have to use a constrained liner and reduce the hip. 7 months follow-up. Now it is 2 years follow-up. She is doing well. We have been dealing with aseptic non-union. Now we come to the infected non-union, which is very common in our country, because it happens in open injuries and or following operative intervention of the fractures. In these, you have to identify the organism by culture sensitivity. You have to do a thorough debridement, excise necrotic bone and soft tissues. You should never give any leniency while you are doing the excision of the necrotic bone, because so long as you keep the necrotic bone, it is not going to heal, and it is not going to end the good result to the patient. You, after the excision, you can do a X-fix. If there is a big bone defect and the soft tissue defect, you can do a soft tissue cover with the help of the flap, like what it has been shown. And once you have got rid of the infection, then you have to do the bone reconstruction. If you are very much not survive with the biological reconstruction with bone transport. You can try for smaller graft with fibular graft, or if you have got a colleague who can do a free fibular graft, microvascular you can do. If the gap is very small, you can also manage with corticocancellous grafting. This gentleman, which I have shown you earlier, this ulna had infection and loosening of that. We removed the entire thing, debrided it, and put up a external fixator and did a bone transport. For the ulna alone, we did not do anything for the radius. And slowly, the infected non-union healed, callus formed above. One good thing is when you are doing a distraction osteogenesis, you get a good vascularization of the entire limb, which causes healing of the most of the other fractures. So radius we have not fixed. We have got no armamentarium there to fix it, but the radius and ulna heal. That is the function of the gentleman. Now, this fellow is a 17 years old boy who had an injury. He was initially fixed with plate and screw, which failed to heal it. He was having a draining sinus and was not walking for 4.5 years. He was a very plunky chap. You can see that the distal fragment has got a necrotic bone still attached to the distal fragment, which was the cause for his persistent infected non-union. So what we did, we resected that bone and Ilizarov frame was applied. We did a corticotomy and we brought the fragment down. You can see that it has been nicely compressed. You can see that all these wires are bent. The bending of the wires is because of the compression which is given at the local side, which resulted in healing of the non-union side, as well as he had a good regenerate. Now, when you are using an Ilizarov frame, you have added advantage. This fellow had a small peri-articular fracture here also, for which we extended the frame. He had equinus deformity of the foot and ankle, which was also corrected. So that is added advantage when you are using it. This is the picture which I showed you in a 68 years old diabetic gentleman who came all the way from Tiruchendur, which is a smaller seashore place which has got the famous Murugan temple. He had the fixation with the plate and screw, which resulted in a ghastly like this. We removed the implant, we removed the necrotic material and applied the frame as shown here for bone transport with fixation of the foot because it is a very small fragment. So we did a 2-level corticotomy to get the union and the local side. We never added any bone graft local side with compression alone this heel because this fellow had really uncontrolled diabetes. Age is not a criteria. You can get regenerate in any age group. He was 60 plus to get a nice regenerate. I have given a bird's eye view of managing various non-unions with examples. There are other avenues available and there are special situations and other modalities of treatment are there which I have not touched. One of them is electromagnetic induction. The second is low pulse ultrasound therapy, which has been managed. People also use bone marrow aspirate to the local site for healing the fracture. Those are the things which probably you have to go through with your own literature. I thank you at this level for your kind attention. If time permits, I can show you 1 or 2 cases. Deepak, you can
Sir,
take.
sir, kindly show the cases, sir. We'll take the questions after that, sir.
Yes.
So for osteogenic stimulus at the fracture site, corticotomy, which I have shown you earlier, I think this is too simple now. After seeing all the example, this is a gentleman who had an inadequate fixation of a fracture of the tibia with just 2 screws below the level of the fracture, right? He had infection also, so implant removal and simple frame with an for osteogenic potential proximal corticotomy, healed in 4.5 months time. This is a very, very peculiar fracture. Of course, a compound fracture in a teacher from Srivilpittur. He was not married. He had this one, and the entire skin is only skin graft which has been applied, and it is over it. You can see that the fibula is hitching onto the distal fragment. There is a very small segmental fracture in the middle, and the proximal segment is there. Now, whatever movement is happening at the proximal non-union side, the distal fragment was moving with the proximal fibula. And that is the one which was causing the more problem for him. He also had shortening. He had a very stiff foot and ankle. With this, he came to Government General Hospital. So what first thing which we did was the fibula which was causing a strut mechanism on the lower side, we undid that. And then a proximal corticotomy was done. The distal non-union side was compressed. Now we have got an oblique non-union proximally and distally. So proximal corticotomy, we slided the bone down to get a end-to-end apposition. And after that, we used olive wires so that we can get a non-union local site. His skin is not allowing any opening procedure to provide any bone graft. So Ilizarov has given an example of where you can make a small stab incision, use a fine chisel and make the area raw. So we did that technique, and it healed the bone proximally, distally. For his shortening, we did a lengthening of that fragment. During the lengthening, he had delay in regenerate, but once we added 2 rings above, it all healed. Whenever you have got problem of the regenerate will be wavy in nature. If you have got a good stability, then you will find that the regenerate will be totally in one single segment. Whereas a wavy regenerate, as you see in the proximal area, is an example where there was some instability during the time of treatment for him. You can see that pre-op and post-op, his limb length has become equal. His skin looks very, very black. Later on, we got the consultation from the dermatologist. They gave some potassium permanganate solution. Gradually, this black coloration was disappeared. After this, he came with a marriage invitation. He is married. He has got now 2 kids. Still comes to my clinic. He was treated way back in 90s in Government General Hospital. One more example of a 14 years old boy who had compound injury during the childhood. He was never treated. You can see that there is a gap non-union. He has been weight bearing and his fibula has grown longer. You can see that the superior tibiofibular joint, inferior tibiofibular joint, both are subluxed. So when we want to treat these fellows, you have to address all these. You also have got a varus deformity of the entire fibula. So these are the problems which I have told already. There is a hypertrophied fibula, varus angulation, distal tibial growth there is a length, there is a gap, rotation, varus angulation of the foot. all these problems were there. So what we did initially, put a frame with wires only in the tibia for the distal fragment with one Schwann spin. Above there was a single ring with adequate fixation. Fibular osteotomy was done to correct the deformity. Once we corrected the deformity, we corrected the tibial deformity. That was the apex of the deformity. So you can see that the ring construct and the hinges. So end of the story, where we brought the fibula which was above to the level which is down. The inferior portion of the inferior the tibiofibular joint was also reconstructed. You've got a straight tibia which is short, but the bone has nicely healed. This is the pre-op and that is the post-op. I think it took about 1 year for this boy to have the entire treatment in Government General Hospital. I don't know whether this, I think it will work. So video is not working. He had still shortening of the limb, which we later on, we did a lengthening of the limb later on. He had equal limbs on both sides and he walks well. Gained 5.3 centimeters. I think that's all. That's the end of my lecture and two of the interesting cases which I wanted to share.
Yes, sir. It was excellent presentation, sir. You have nicely explained the principles of management of the non-union and supplemented with the clinical cases. Thanks for sharing your experience. We'll take up some questions, sir. Shall we take it, sir?
Yes.
Someone is asking, what is wave plate and how does it help in non-union?
Wave plate.
Yes, sir.
Wave plate is, I'm not aware. I think probably they are talking about hypertrophic non-union where they circumvene with the bent plate. I'm not.
Yeah, it's a bent plate. Like I think you showed in one of the images, first where you circumvent the non-union and it accommodates some bone graft. That is the reason why. I think you showed in one of the images.
That is
bridge plating.
That's a wave plate.
So someone is asking, after how many days after removing the infected part of the non-union shall we use the bone graft?
After the excision of the infected non-union, how many days later you can do your bone graft? Is this that question?
Yes, sir.
Yes.
You have got an adequate fixation once the infection subsides. Probably it takes about 6 to 8 weeks of antibiotic therapy after identifying the organisms. You have to wait for the entire healing of the soft tissues, subsidence of all the sinus tracts. Then only one can think in terms of putting a bone graft in the local site. Immediately one should not do. And immediately one should not do corticotomy also if you are using an Illusorov frame.
Yes, sir. Point well taken, sir. Someone is asking, can we use LRS with the bone graft in non-union TPA? Can we apply it?
For which situation? You can use, instead of Illusorov, you can definitely use LRS system, which will allow fixation of the bone, which will also allow you to bone transport. You can also do deformity correction with LRS also. Now, if there is no sepsis at the local site, you can definitely do a bone grafting at the dog site, which I have shown in various examples. Is that a satisfactory answer for the person?
What is?
Yes.
Yes, sir. I think you have answered nicely, sir. So what is the common bone substitute used for non-union?
Now, there are multiple bone substitutes available. Mostly they are all calcium sulfates which are available in the market. If your patient is very much affordable, you can use a BMP along with this bone graft substitute, which is a calcium sulfate. Both AO as well as the other companies, they market these bone graft substitutes. I have been using it for quite some time. Along with that, I also use allo as well as the autografts, which we harvest from the patient. But most of the time, other bone graft substitutes like G bone, I have very bad experience because that they never get incorporated at the non-union side, and that has to be removed when we are dealing with reoperation with a G bone at the local site.
So can I ask a question, sir? What is your
They
experience
are
with
mostly
this
used as a
BMAC?
bone fillers.
BMAC, sir. BMAC. What is your experience with the bone marrow aspiration and injection?
Bone marrow aspiration injections, I have done only few, and out of the 4 or 5, we had 3 unions and 2 of them did not heal. Maybe because there was a nascent infection in the local site, which whatever BMAC we provided, it was eaten away, and we have to do reoperations with external fixator. Are you using a lot of BMAC?
Rarely, sir, but we don't use the commercial one. We just do the aspirate from.
Long ago, some 20 years ago, CMC Vellore people, they brought out one paper in TNOA where they used saline injected into the 2 tables of the ileum, aspirated it, and then injected into the non-union side with some 82% union at the fracture side.
Yes.
That is one which I can quote, where they have just aspirated the bone marrow content from the ileum and used it for the bone graft.
Yes. Deepak, there are 2 more questions I think you can ask, sir.
Yes, sir. Someone is asking, do external fixator provide union in a bone, sir?
I have shown so many of the examples where I use only external fixator and used it as a tool for uniting it. The question is whether AO type of a tubular external fixator, whether it will heal?
Yes, sir. They are asking about AO type of external fixator, because many a times we have seen that it goes for a non-union or delayed union in external fixator. Again, we need to change it to the definitive fixation.
No. AO tubular external fixator is also a very good tool. You can, if you are judiciously using that, you can definitely get a healing. Now, you should have adequate spanning of the pins, and while putting the shank pin, you should use a sharp drill bits. You have also used the saline wash when you are drilling it, and there should not be any bone necrosis at the local site. And when we are adding these shank screws, you should have stacked external fixture. We cannot have just 3 clamps above, 3 through, or 3 clamps down, and get a union at the local site. Probably a biplanar fixation, or from the same shank pin, 2 types of parallel fixation with clamps will be of great help. You can still get a union with the AO tubular external fixator if your pin fixation is good and pin care is good without any infection. You can still succeed in getting a union at the fracture site.
Yes, sir. Following the proper principles, we can achieve a union in the external fixator also. And someone asking, sir, kindly give some tips for distraction in Elizardo. What are any tips are there for a distraction?
Distraction.
Yes,
Now,
in Elizardo.
More important is doing the corticotomy properly. If you do a corticotomy properly, either you can use Elizarov type of an osteotomes, or you can use minimal opening type where the periosteum is nicely stripped all around, they are well maintained, then you can see, you can make multiple drill holes, weaken the cortex, and do the corticotomy. Or I use the giggly saw method, where I preserve the periosteum and do the giggly saw. I wait for at least 10 to 12 days. If I use an osteotome, if the corticotomy site has got a little bit of a comminution, I wait for 2 weeks before I do a distraction. And distraction, we teach them how to do it, and we use the square nuts so that it becomes much simpler for the patients to do the distraction on their own. And it is 4 times a day, quarter turn in the morning 6, 12 o'clock, evening 6 o'clock, and before they go to bed around 11 o'clock, they will do the last distraction. You have to monitor after 1 week later whether the fragments got distracted. In orthofix, if you are using an orthofix type of an external fixator, after doing the corticotomy, you can actually distract the corticotomy site 2 millimeter, find out whether your corticotomy is complete. Similarly, in Ilizarov also, you have to find out whether your corticotomy is complete by doing a C-arm image intensifier, and find out whether you can distract it at the local site, and then compress it, wait for 10 to 14 days, and then do the distraction. Is that a tip which is sufficient, or anything else they want? Because
No, sir, you have beautifully explained it, sir.
every day the patient has to measure the distance between the two distracting rings with the help of a scale, so that 4 corners they can find out whether they are equally distracting. Sometimes if they distract on one side more and one side less, the rods will start bending, which will cause instability at the site of the distraction side, which will cause non-union at that level.
Yes, sir. Points very well taken, sir. On behalf of Devdas Hospital and this forum, sir, I thank you for your valuable time, and thanks for sharing the experience on the non-union of fracture. And it was very wonderful.
Thanks, Professor, for giving this opportunity. And I would like to know what is the feedback of this lecture from the audience, whoever I've seen.
Yes.
Okay. Thank you, Govardhan, for the excellent exposition of your favorite talk, which I enjoyed very much. I always enjoy all your lectures. That's why I give you this topic, because the candidates, when they go to the exam, they will remember all the tips, all the classification you are told in the exam to the examiner, and I hope it will be of much use to them. Thank you.
Thank you, sir. Thank you very much for the opportunity, sir. Thank you.
Thank you, sir. It was an excellent talk, sir. I think you cleared most of it. Very simply and nicely you dealt with them, and also the cases looked really amazing. What you have done, you got a really green thumb. It looks very nice, sir. And basically because you are using the correct techniques, and you have shown to this. So thank you so much, sir, for being part of this teaching program, sir. We look forward to seeing you more often, sir, in this program.
Thank you.
Thank you.
Thank you.
Good night, everyone. Yes.
Yeah. Good night. Thank you.
Deepak, you can announce next week.
On 19th of June, we have Professor Nali Uraj sir from Chennai. He's going to speak on spinal fracture and the classification and the management. So please spread the word among your colleagues and friends that we have moved to the Zoom platform, and we are also available live on YouTube. So kindly attend the last number. Thank you, everyone, and good night. Take care.